Good morning, everyone. My name is Melanie Escher-Blair, and I'm with the Arizona Telemedicine Program in the Southwest Telehealth Resource Center, and working with the CHEC, which is the Southeast Arizona Health Education Center, and then the Santa Cruz County Adolescent Wellness Network. We have Dr. Corey Daines with us today, who's going to be talking about pediatric lungs and COVID-19. A couple little housekeeping, your mics and your cameras were off when you joined. We will be using the chat feature on the bottom of your screen. If you toggle over, you'll find the bubble window that says chat. You can turn it on. It'll open up a column on the right-hand side, and you can type in your questions for Dr. Daines. We also have an evaluation that populated in a separate window that you'll be able to click on, do the evaluation, and request your certificates. So without further ado, I'm going to introduce Ms. Corey Daines here. So Dr. Corey Daines, she's a professor of pediatric pulmonary medicine at the University of Arizona in Tucson, and the division chief of pediatric pulmonary medicine. Dr. Daines received her undergraduate degree from Texas A&M University and her medical degree from St. Louis University. She completed her residency in pediatrics at St. Louis University, the Cardinal Glennon Children's Hospital, and her fellowship in pediatric pulmonary medicine at the University of North Carolina. She was faculty at Cincinnati Children's Hospital prior to coming to Tucson in 2007, and she serves on several national committees for the American Thoracic Society and the Cystic Fibrosis Foundation, and is funded with grants from HRSA and the Cystic Fibrosis Foundation. So with that, Dr. Corey Daines, mic is all yours.
All right. Well, I appreciate it very much, Melanie. So thank you guys for spending a little bit of time with me this morning. I think that this discussion is very appropriate and well-timed right now as we're talking about COVID-19 again. I think maybe we felt as though we had avoided the really awful things that could potentially happen with COVID and children. And I think we're learning now with this newest surge that maybe not so much. And it is affecting our children, and it is affecting them from a pediatric standpoint, from a lung standpoint and a pediatric standpoint. So I'm going to focus today on COVID-19 and the pediatric lung and what happens in the pediatric lung. But I'm also going to spend time talking about what we know and what we don't know, and what we're about to find out, I think, as we move forward through this COVID landscape. So as we go through this, I will talk about what my disclosures and objectives are. As Melanie suggested, I do clinical research, and one of the clinical research companies that I do trials for is Vertex. I also, as she said, have funding from the CF Foundation and from HRSA to do training and clinical support. So in terms of objectives here, I think that these are some of the things I want to kind of go over today. I want to talk about the incidence of COVID-19 in children. I want you to understand how this manifests itself in terms of pulmonary disease in kiddos. I want you to be able to evaluate COVID-19 and MIS-C, these two diseases in children, to be able to evaluate the long-term pulmonary consequences of COVID-19 in children, and to help to evaluate and treat children with COVID-19 symptoms, both acute and chronic, and how we move from there. Next, I think we need to take it back a step, and I want to try to go backwards to your basic science and explain a little bit about how COVID-19 infects the body and what it does in the body. And maybe that'll help us to understand a little bit more about the symptoms that not only children but adults get, and why there might be long-term consequences for kids as well as adults. So this little diagram from the British Medical Journal shows a little cartoon of our COVID-19, our SARS-CoV-19, and has the spike proteins on it, these little red spike proteins. And those spike proteins are the proteins that attach to the receptors on epithelial cells. And the receptor that it specifically attaches to is the ACE2 receptor. And this is a really common receptor in the angiotensin renin pathway. And we have ACE receptors on almost every organ in our bodies. And that's part of the reason that COVID doesn't just affect the lungs, but affects a lot of the other organs. So what happens is the virus gets into the body via mucous membranes, usually the upper airway mucous membranes, the nose and the mouth. And we have lots of these ACE2 receptors in our upper airway, in our noses and in our pharyngeal airway. And then we also have them throughout the bronchial tree, the tracheobronchial tree. And so the SARS virus gets in, and it may settle out in the nose and in the upper airway and infect those cells, and then be subject to hopefully potentially to mucociliary clearance and kind of clear out. But then it also can be breathed in more deeply and get into the deeper lungs and infect those epithelial cells. And it really kind of depends on viral load. So how much were we exposed to? How much did we actually breathe in or take in, to kind of understand where this virus is going to start its infection and maybe hopefully end its infection. But this is how it gets infected. So it holds on to this ACE2 receptor. It needs to have various proteolytic enzymes available to it on the epithelial cell that help cleave the receptor and allow endocytosis so that the virus can actually get into the cell. If it attaches and those proteolytic enzymes aren't there, then it doesn't necessarily get brought into the cell. But if it gets brought into the cell, then it causes typical viral infection. So it extrudes its single strand of RNA. It starts to replicate inside of the cytoplasm of the cell, and it ends up making copies of itself, which then can be distributed throughout the body and cause infection. And this little diagram shows you the various things that virus then does. It causes you to make antibodies because, of course, you have all this virus in the cells. It causes lots of pro-inflammatory cytokines to be stimulated. That's normal for viral infection. It seems to be a little bit more accentuated with the SARS-CoV virus. And then it also causes vasculopathies and issues with our blood vessels. So again, here is a little bit of a diagram showing, okay, it gets into the lung, and it's here's your coronavirus, and it is attaching to the ACE2 receptor. It's being brought into the cell, and here again in the cell, in the cytoplasm, it's going to make its copies of itself here. But what also happens, it gets enveloped, and it has these pro-inflammatory cytokines that brings in new cells, lymphocytes, macrophages, other types of cells, inflammatory cells, which also envelop the virus. And then macrophages carry the virus, or the virus itself gets migrated into the blood vessels, and it travels throughout the body. So now we're not just in the lungs, now we're in the blood vessels, and we're in these and we're going to all of these other organs. And you have plentiful ACE2 receptors in your brain and in your heart and in your liver and in your intestines and in your pancreas and in your kidneys. And so we end up having, depending again on viral load and viral replication, lots of other organs that become affected. So here's kind of the kicker and why we end up seeing more severe infections in high-risk individuals. High-risk individuals have more ACE2 receptors. So people with diabetes, people who are obese, you actually make more ACE2 receptors as you age. And so older people have more of these receptors. Smokers, and in fact, people who are male versus female actually have more ACE2 receptors. The other problem here is that the immune response is failing people in these situations. You don't have a normal immune response if you're older, if you have diabetes, if you are obese. All of those interfere with your ability to sort of have a normal response that's going to help kill off the virus. So then we get this incredibly significant multi-system disease that happens. And the pathogenesis leads to problems in all of these organs. So I'm going to focus on the lungs, of course, but you get edema, you get mucus in the airways, you get damage to the alveoli, you get all this inflammatory process that happens in the lungs, and you can eventually end up getting fibrosis and damage to the lungs long term. But you get this same kind of edema and cellular death in all of these organs. So it causes issues with cognitive impairment, degeneration of neurons. It can cause necrosis in your kidneys and cause kidney disease. The vasculopathies that we see are extensive. There are lots of ACE2 receptors on the epithelial lining of blood vessels. And that then leads to a release of cytokines that causes there to be microthrombi and all of those clots that we see all over the place, including in the brain, including in the body, where we see stroke and other kinds of vasculopathies are really, really common in significant disease. It hurts the heart. In the blood vessels in the heart, people can have myocardial infarctions due to this. And then again, in the GI tract, we have significant problems across the board. So it really does get into all of these organs causing problems. So I'm bringing all this up so that when we talk about the symptoms that people get, you'll kind of understand this is a multi-system disease. It is not just in the lungs, even though the lungs are very likely the primary organ. So why do we care about kids right now? Well, I have to admit this was an incredibly timely talk because right now we are seeing a spike in the incidence of COVID-19 infections in children. So this is national data and is pulled off of the CDC website. And you can see here last week, I didn't do right now because you can see right now we don't have complete data for after a week for the most recent week. But what you do see is that while we still see a large number, so this is per 100,000, the number of cases that we're seeing, we still see the highest number in the young adults. Realize that these numbers in children are extraordinarily higher than they used to be. And you'll notice that the incidence in children from 17 on down is higher than it is in people who are 65 and above, really for the first time since the pandemic started. So lots of disease in kids right now. Now, if you're interested in what's going on from a hospitalization standpoint, again, this is recent CDC data looking at the beginning of August. We are seeing the most hospitalizations for children with COVID that we have seen throughout the pandemic, including in our peak year, in our peak time in January and December of last year. More hospitalizations now than we have seen at all. So our kids are getting sick. Our kids are ending up in the hospital, and so it's an important thing for us to be talking about. Where are we in Arizona? This is the most recent data from the Arizona Health website, and you can see total less than 20. Our numbers are climbing. We now have more cases in our under 20 group than we do in our over 65 group in the state of Arizona. And if you look at this as compared with the total, we're hitting 15–20% of the total cases in Arizona are now in the youngest age group, and that did not used to be true. But where is it directly right now? This is data that was gathered by the University of Arizona's College of Public Health by a public health epidemiologist, Dr. Joe Gerald. And he publishes our weekly data to look at where we are from an incidence. Going back to March, you can see our levels of COVID infection have gone up dramatically in the last month and a half. And you can see still the highest age group in terms of incidence is our 15 to 24-year-olds. So our young adults, our college age students. And if you remember the last graph I showed you, when I showed you what the incidence was nationally, you'll see that the incidence here in Arizona is higher than it is nationally. These numbers were like 174, 175 per 100,000. Nationally, we're above 300 cases per 100,000 here in Arizona. But look at this number. This is your 0 to 15s. And our incidence in our 15 and under crew are now about 250 cases per 100,000 for this first week in August. So our rates are going up. If you want to look at where the kids themselves settle out, while the highest incidence is clearly in the 15 to 19-year-old age group, look at our less than fives. We're about 150 cases per 100,000 in the less than 5 group. So it's across the board. It is not only in our teenagers who, by the way, could be immunized, but it is across the board for children. And this scares us a little bit, especially as we head into school and realize that these kiddos are all going to be in congregate settings in the next couple of weeks. Now, the next slide is just kind of looking at a breakdown, and you can see in the bottom here, we are looking again this first week in August. The peak ages are still in the young adults, but our incidence in our kids is going way up. And now children in Arizona account for 18% of all of the cases in Arizona. At our peak, it was about 10%. So our kids are at risk. And that's the big point that I want you guys to have heading into this talk. So what are the symptoms of COVID-19 in children? They're the same as you've heard for adults. Typically in children, the symptoms start 2 to 14 days after an exposure and start with symptoms of regular viral illness. So fever and chills. The kiddos can have cough and runny nose and congestion, but they might develop more significant respiratory symptoms like shortness of breath, difficulty breathing. They're going to have kind of typical virally achy symptoms of headache, sore throat. That loss of taste and smell, we're going to focus on a little bit. You guys have heard that that's a common thing in COVID-19 infections, and it may be one thing that helps you to distinguish when you're seeing a child in your office. You know, does this kid have COVID? How frightened should I be? And how likely should I be to see if that is what's going on with them? And of course, it can affect the GI tract as well. So I want to give you a sense of what we know traditionally in terms of symptoms affecting children with COVID-19. This is from the Canadian Medical Journal. And this is a study done in Alberta looking at children who in Alberta had swabs for COVID-19 because they had symptoms. So these are all under the age of 17. And you can see in this cohort in Alberta, of the children that were swabbed, a very large proportion of them did actually have COVID-19, were positive for it. And you can see it runs the gamut across the board from 0 to 4, all the way up to the 13 to 17-year age group, okay? Now, what I want you to look at here in terms of symptoms, and I want to try to be clear with this graph. These are the symptoms over here on the left-hand side. The first column tells you if they had a positive swab. So these are patients with COVID-19. The second column shows you if they were negative for COVID-19, and you'll see numbers. And then you'll see an odds ratio for that particular symptom. And you'll see what tops the list is this loss of taste and smell. And so in the people with a positive COVID swab, the number that actually had loss of taste and smell was 153. But the more important number here is probably the percentage. It's not a large percentage, right? Only 7.5%, 8% of the kiddos had that. But it was a distinguishing symptom because only 1% of children who had a negative swab but were sick actually had this symptom. So our odds ratio for loss of taste and smell is very high, meaning you have a kid that has that symptom, then it's very likely to be COVID, even though you may not see that symptom. And obviously there are symptoms that are far, far more common. 15% had sore throats. We had a large chunk of kiddos that were asymptomatic up here. We've got sneezing. Fever was very, very common in patients with COVID-19, but it was also common in those that didn't have COVID-19 and had some other viral illness. So it's not distinguishing. Headache, common in COVID-19, maybe a little less common in not COVID-19, but our odds ratio isn't the same. Cough, lots of kids had cough, but even more kids had cough if they didn't have COVID-19 in terms of a percentage. So when you're thinking about distinguishing factors, it's that loss of taste and smell. It's maybe the GI symptoms and the headache that are more common in COVID-19 than other viral illnesses. But the viral symptoms of cough, runny nose, and fever are definitely very, very, very common. This is, again, looking at sort of odds ratios of what happens here in terms of your loss of taste and smell, nausea and vomiting, and headache. And you can see all of them have a higher odds ratio than these other types of symptoms, such as sneezing and fever and malaise and fatigue and cough. Those all are very common, but they're not specifically distinguishing. This was another study done in a different group of children in Greece, again, looking at what the prevalence of symptoms are. And loss of taste and smell was only about 10% in this group, whereas fever, runny nose, and cough, these were the common symptoms that we saw in COVID-19, just as you would expect, same as other viral illnesses. So what I want to switch to is to tell you about the scary things that you may be looking out for your children in terms of symptoms. So we have this entity that is really isolated to children called multisystem inflammatory syndrome in children's, our MIS-C, and you have heard this syndrome. And so when you're looking at children in the hospital or in your clinic and you're wondering, are they sick? Do they need to be hospitalized? Do I need to intervene? This is a group of children that we should worry about. MIS-C is seen almost entirely in children under the age of 21. In fact, that's one of the diagnostic criteria, although the CDC will tell you there's at least 1 or 2 cases in 21, 22-year-olds. But I think at less than 21 is the diagnostic criteria. These are children who have fever, and it's been there for a prolonged period of time. They have evidence of inflammation, and this is where you have to get blood work in order to know what their inflammatory markers are looking like. So these are kids that are sick, they're coming to your office, they have fever, they may not actively have the respiratory symptoms, they're not going to look like they've got a cough and a runny nose and like they have a viral illness, but they're going to look sick and they're going to have fever. And these children, you need to check their inflammatory markers, and you need to worry that they're going to have other organ involvement. So the diagnostic criteria here are fever, evidence of inflammation on blood work, multi-system involvement. You have to have at least 2 organs involved to have this multi-systems issue. No alternative diagnosis for why this has happened. And the children have to either have had a previous COVID-19 infection or been exposed to a confirmed case of COVID-19 where the exposure was pretty significant. And that has to have happened within the last 4 weeks of these symptoms arriving. So this is an interesting phenomenon. The last one I would say here, because a lot of kids end up don't go and get a swab for COVID-19, but say a family member got a swab and had COVID-19. A lot of our recommendations are, if the kid is sick, keep them home, isolate them, pretend they have COVID-19. So really our numbers of COVID-19 in children are probably underestimated. There's a lot of children out there who have probably had it, who were never tested because their families just isolated in place since they knew COVID-19 was going through the family. So if you're looking for symptoms beyond this initial infection that are severe, and this child shows up in your office and yeah, mom had COVID-19 3 weeks ago and the child was sick too, but we never got the kid tested, that counts. If they have these symptoms of fever and look sick, you should look for this MIS-C syndrome because this can be deadly. So knowing more about MIS-C is important because from again, the CDC website, we're looking at the Morbidity and Mortality Weekly Report that has come out looking at MIS-C in children. That children tend to fall into 3 categories if they have MIS-C. The type 1 is where they go into shock. These are kiddos that clearly need to be in the hospital. They have significant problem with multisystem. They have lots of GI involvement and cardiovascular involvement. They go into shock. They have myocarditis. They have lymphopenia. They have high inflammatory markers, and they're sick as anything. And these are children who need inpatient management for sure to be able to get over it. That's the first phenotype. The second phenotype are children that look like the adults who get bad respiratory distress. And these are kiddos that not only look sick and have the fever, but they're going to have cough and shortness of breath. They may have pneumonia. They may go into ARDS, and they have a very high case fatality rate. These kiddos are older kiddos, often 10 and above, and these are the ones that get sick and often die because of respiratory complications. There's overlap here. It's not just a multisystem inflammatory issue. They also seem to have respiratory disease. This is the second type of MIS-C we see. The third type look like Kawasaki's disease, and these are really younger kids who mainly present with rash, mucosal lesions, and they tend to have lower inflammatory markers. And again, they look sick, they have high fevers, you don't have other reasons. They might actually fit Kawasaki's criteria, but these are children who've had an exposure to COVID-19 or had COVID-19 themselves. So this is what MIS-C looks like. Okay, and so we're going to be on the lookout for this as we think about long-term complications or complications in the lungs with COVID-19. This is just an incidence of how often we're seeing MIS-C. You can see we've had over 4,400 cases that have been diagnosed and reported to the CDC. In Arizona, those numbers are between 100 and 150. If I looked at this graph correctly on the website, it's 129 cases in Arizona. So we are seeing it here. So please be on the lookout for these cases, especially now, because we're seeing a spike in the number of children getting sick with COVID-19. I want to just take one moment to talk about that phenotype number 2, where they have respiratory symptoms, and talk about the confounders. So our teenagers, they may potentially be smoking or vaping as well. And here's the confounder. ACE2 receptors, those receptors that bind the COVID-19, they are higher in people who smoke and who vape and are upregulated. And that means that kids that are smoking and vaping are more likely to, when they have an exposure to COVID-19, to get sick with it, and to get sick with it in a pretty profound way. The ICU rates are much higher in smokers as well. So what happens here in COVID-19 is the same as what happens when you get like the EVALI lung injuries. Both cases, you get inflammation in the upper airway. The ACE2 receptors get upregulated here and binded with COVID-19 here. Both of these things, cause you to have inflammatory cells released, upregulation of these inflammatory cells, and can lead to cytokine storm and multisystem organ dysfunction, and may be at least part of the reason that type 2 MIS-C happens in people with respiratory symptoms where they also have inflammatory markers. I'm just going to show you a little snippet from the Journal of Adolescent Health, which shows that children and youth, and here we are, who are smoking or vaping. These are all children and youth between the ages of 13 and 24. And if they are smoking or vaping, what you end up seeing is that they are more likely to have COVID-19 symptoms. And this is very common in children who smoked and vaped. Now, of course, because if they're smoking or vaping, they're going to have cough and fever and all those symptoms. They're more likely to go get a COVID-19 test in terms of their odds ratio, but they're also way more likely to have a positive COVID-19 diagnosis. Again, those ACE2 receptors at work. Our incidence, if they're smoking and vaping, of positive COVID-19 test odds ratio is 7 times normal. So if your adolescents are smoking or vaping, this is one thing you can try to intervene on now, realizing COVID-19 is out there. Get them immunized, try to keep them from doing this to harm themselves, because they're putting themselves at significant risk for complications from COVID-19 if they're smoking and vaping as well. So I want to focus now on what the long-term effects of COVID-19 might be in adults and kids, and then go a little bit into treatment. So in adults, you can see this is a report from the Netherlands where they looked at people who got COVID-19. Of these people who got COVID-19, most of them were not hospitalized. So this would be considered mild COVID-19. And what they did, and granted this was just a survey, but they looked at symptoms during infection. These are the heavy bars here. And then the light bars are at follow-up. And their follow-up was at 79 days. So 2.5 months after the COVID-19 infection. And what you can see is that a vast majority of these adults were still complaining of symptoms during follow-up. So what we've got here is a lot of fatigue, a huge percentage, 71% were still complaining of dyspnea, a lesser number of headache. Chest tightness was over 40% of patients. We still had cough in about 30% of the patients, and then other symptoms of all of those different organs that are involved in the COVID-19 pathway. So these long-term symptoms definitely occur in adults, and you've heard about it. You've heard about long haulers and people with COVID-19 symptoms that just do not seem to go away. This study, which was in Nature Medicine, actually looked at long-term symptoms at 3 months out in a whole spectrum of people. And you'll notice here they've got a 0 to 15 age group as well as the older folks. And what you can see is that at 6 months out, in terms of symptoms, the kids didn't have as many as the adults, which is great, right? So our adult studies focus here are like, they say, okay, wow, we've got 60% of people who are older who had COVID who still have symptoms at 6 months post-COVID. In children, not so much. The children tend to recover a little bit better, but we still have 13% of our kiddos in this small study that were having long-term symptoms as much as 6 months out from their COVID infections. You'll notice here from a respiratory standpoint, not so much, not cough, not dyspnea. That was happening in the big people, but not so much in the children. So let's see, do we have long-term lung effects for children? So this is, again, an Italian study. This one was looking at persisting symptoms in children. You can see a lot of them had had a little bit more fatigue than they had before, and had some runny nose and congestion, but muscle pain, headache, lack of concentration. But again, from a respiratory standpoint, chest tightness, 6.2%, chest pain, 3.1%. So fewer respiratory symptoms, more malaise, fatigue, muscle pain in children from a long-term standpoint. And this was in Italian children. Okay, I'm going to switch gears on you guys a little bit as I think about, okay, so what do we do to treat people acutely with COVID and chronically with COVID, and then what do we worry about from a lung standpoint? And that's how we'll proceed from here. So when we have children that are sick with COVID-19, how should we treat them? Well, if they're hospitalized, we should think about if it's mild and they're not hypoxemic and they're not requiring oxygen, just supportive care. This is from the British Medical Journal, and it shows that there wasn't a real clear benefit from remdesivir or convalescent plasma or steroids in children who really did not have severe disease. And so supportive care may be the way to go. But if they're getting hypoxemic, or they have a progression in their lung exams, then treating them with steroids. Remdesivir may be of benefit, and some of the monoclonal antibodies or the other immunosuppressive medicines with consultation from ID and other folks are possible. Same is true if they're severely sick, hospitalized, intubated, needing ECMO, those types of things. You again would want them on steroids, considering remdesivir and considering other biologics to control things. But children, by and large, if they are not severely ill, supportive care is the way we're going to treat our kids actively with respiratory distress. Now, we can think about how we're going to treat them from a lung standpoint, and this is the same as we'd treat big people with COVID. We would want to try not to intubate them. We would want to try non-invasive strategies if we can, oxygen therapy, lung clearance to keep their airways clear, airway suctioning. And then treating them as if they have severe disease with more invasive ventilation techniques to help keep their lungs open and clear from mucus. But the NIH has put forward guidelines on how we should treat children acutely and chronically when they have MIS-C. So here's the kicker. There are no randomized controlled trials in children. We don't have any references to know what works and what doesn't work in children. And generally, we do know that COVID-19 is milder in kids, requires no specific therapy, but we also know we have high-risk children. We have children who may need more interventions because they have severe disease. So supportive care is the way to go 100%. If you have a child in your office that's diagnosed with COVID-19, don't hospitalize them if they don't need to be hospitalized. The vast majority do not need to be hospitalized. If they do happen to have the post-COVID MIS-C symptoms, that's more likely to need a hospitalization and more intensive interventions in order to get those kids through those problems, because they can be life-threatening. So most COVID, when they're visiting your office, we're going to manage supportively. What other therapies can we use? Remdesivir, you guys have heard a lot about remdesivir. Remdesivir is an antiviral, which has been shown to be at least partially effective in people acutely with COVID-19. In children, it should really be isolated to kids who are over the age of 12 with severe risk factors needing oxygen and who are in the hospital. You can consider it in anybody who's an older teenager, even if they just have an oxygen need. But the younger teenagers, if they are not at high risk, if they have an oxygen need, it's really something you need to take under consideration depending on how bad their disease is and how quickly it's progressing. The NIH uniformly says, talk to ID, consult with specialists before you decide whether or not to use these antivirals in children. Dexamethasone, I would suggest that as pediatricians and family practice docs and primary care docs, we use a lot of steroids in kids, and we do use it on the outpatient setting. The NIH guidelines for children would say if they're hospitalized, if they have extensive oxygen needs, you should definitely use dexamethasone. In any child that is at high risk, you should consider the use of dexamethasone. And here I'm expanding what the NIH says a little bit. I'm going to tell you that kind of depends on what you're seeing in your office. If you consider that child in front of you to be at high risk because of other respiratory problems that they have, other problems, congenital problems that they have, you should consider to use dexamethasone in the high-risk children. In your run-of-the-mill child in front of you in the office with COVID positivity, especially if they don't need to be in the hospital, especially if they're not hypoxic, dexamethasone should be an afterthought. You shouldn't need to use steroids. Not routinely recommended in mild cases or low flow oxygen cases. In the hospital, you can use alternatives to dexamethasone. You can use alternatives in your office to dexamethasone if you think something would be better tolerated. But really, again, let's focus on the high-risk children. They're the ones that are going to have the complications. What else is out there? Same thing is available to children that is available to adults, and these are almost all going to be only in hospitalized children. We do have monoclonal antibodies to SARS-CoV-2. Those are approved above the age of 12, but again, really meant to be used in high-risk individuals or people who are deteriorating rapidly. Convalescent plasma we have for use. There's some use of convalescent plasma in the outpatient arena for high-risk individuals, but we have no data on pediatrics. It isn't necessarily approved in pediatrics. If you're thinking you've got a really high-risk individual and they're either very mild in the hospital or they're in front of you in the office, you really kind of want to think about whether or not that is something that you want to use, because there isn't any pediatric data. And then we've got other anti-inflammatories that can be considered and don't have any pediatric data for them, but have been considered in adults for very high risk, rapidly deteriorating children. For MIS-C, if they're in the hospital, again, likely supportive care, but here's where anti-inflammatory immunomodulators can come into practice. Usually steroids and IVIG are the most common things. You can use more specific immunomodulators, anti-IL-6 and anti-IL-1, but once again, that's going to take some specialty care if you're battling that inside the hospital. So those are all your NIH guidelines. So what about persistent symptoms in COVID in children? In the UK system, going back to this, 13% of children, young children, still had symptoms 5 weeks after infection. 15% of the 12 to 16-year-olds still had symptoms after the 5 weeks after infection. And that runs the gamut of all of the different organs that are involved in COVID-19. So in adults, what happens from a lung standpoint is in these next couple of slides. 3 months after a severe COVID infection in PFTs, this is what we see, pretty normal. There definitely is a restrictive pattern in a couple of these patients. Altered diffusion seems to be the biggest thing that happens, but then the fatigue plays a role here in the 6-minute walks. They can't go as far as they used to be able to go. Their distance isn't as long, so those seem to be the biggest things that happen. If we look at imaging, imaging was only normal in 3 or 8% of these CT scans that were done in these same adults. And a large number of them at 3 months had some evidence of ongoing fibrosis or a change in fibrosis. Now, to show you what I mean here, this is an image from that paper. This is acute. These are all the infiltrates that you saw in acute COVID with pneumonia. And 3 months later, you can see that there's evidence of some fibrosis in some of the areas where there was infiltrate earlier on. So fibrosis and some scarring seems to happen in adults. This was a different study with individuals who really had significant COVID pneumonia. A whole 42% of these patients had residual disease, as you can see here in this bottom panel, where there was fibrosis in the lung in a patient that had COVID pneumonia. This top panel shows you someone who completely resolved. So a good number, even with COVID pneumonia, completely resolved. Do we worry about long-term lung consequences in kids? Yeah. Do we have any data? No, not really. But the symptoms are clearly there in some children who have persistent COVID. They're going to come to your office a month, 2 months, 3 months later and have symptoms of cough and have symptoms of fatigue and shortness of breath. And you're going to have to say, you know, this could be long-term COVID symptoms. Children are at risk at MIS-C for MIS-C, and you should always be on the lookout for that. And data suggests that we should be watchful, especially if our children have underlying conditions. I'm showing you one of my patients who was hospitalized with COVID-19. This was her acute film. You can tell something's wrong with her because she has a tracheostomy tube. So this is obviously a high-risk individual. This was acute in December. This was a month later in January, still with pretty significant disease. And by April, we were pretty clear. So we did end up clearing it, but it took us a long time to actually clear the infiltrates and her symptoms. So what does our Academy of Pediatrics suggest? That all patients who test positive for COVID-19 should have at least one follow-up with their primary care physician after quarantine and before returning to heavy physical activities. If their symptoms were moderate to severe, you absolutely should see them in your office. If they were mild, a telemedicine visit is okay. Encourage vaccination in anyone who is possibly vaccinatable. and come up with a plan to help them return to school. A lot of these children have lost a lot of school time. They may have neurocognitive complications from their COVID, and they may need makeup plans and good communication with the school. If they had moderate to severe COVID-19, do a screening EKG. The American Heart Association says do that, or do a cardiology evaluation to make sure that they don't have cardiac complications and thromboemboli. Be watchful for the MIS-C because it can happen in that 2 to 4 week time frame, even if you didn't know that they had COVID to begin with, and monitor for symptoms. If they have cough and chest pain and dyspnea ongoing for over 3 months, get a chest x-ray, see what's going on. If they're 6 and older, get some lung function testing on them if they're having these persistent symptoms, and see if they have any ongoing lung issues. And consider, again, the cardiovascular evaluation, looking for things like pulmonary embolus and thromboembolic events. What else? I'm just going to hit the hot topic. You know, the kids are going back to school. We really need to advocate for our schools to be as protective as possible to help our kids from getting sick. They should be cleaning surfaces, good ventilation, hand hygiene, face mask use, excluding sick children, and vaccinating everyone who's vaccinatable. We should advocate for our schools. The websites that are best for you to use here are cdc.gov, your aap.gov. There's lovely COVID guidelines from the NIH that I've referenced there, and the state health offices can also help you with your recommendations. And I've run out of time. So Melanie, what do we have?
We actually do have one question. Speaking of the immunizations, we have a gentleman that asked, how soon do you believe that we're going to be able to start immunizing the under 12-year-old and the under 6-year-old age groups?
I love it.
Any
That's
thoughts?
a great question. The data from the FDA would suggest that we will probably be down to 6. I'm crossing my fingers here, end of September, okay, that we'll have emergency authorization use by the end of September. Obviously, we are all interested in our preschool children as well. That's probably going to take a little bit longer. I'm hopeful by the end of the year, but that's kind of a pipe dream for me. I think we really want to push to get our kids that are in school immunized, and so getting it down to 6 will be a big bonus for us to be able to do that. The FDA looks like we're on track for hopefully by the end of September.
Another question, are kids with asthma more susceptible?
So the answer to that is an interestingly no. It seems as though kids with asthma, especially mild asthma, and I'm going to qualify here, they seem to not necessarily have more risk for COVID infection than other children. So at risk for COVID infection, no. At risk for severe complications of COVID infection if they get infected, yes. So there's where the mix is. If they have asthma, they have underlying inflammatory disease in their lungs and dysregulation, you have to worry about them as being your risky category. So if they get COVID, those are the kids you want to think about whether or not you want to give them dexamethasone in the office because they are higher risk, but they're not at more risk for actually getting COVID.
Gotcha. One last quick question. What are the underlying conditions that can result in serious illness of COVID in children? You kind of touched on.
Yeah, the main things are significant immunomodulatory problems. So children who are immunosuppressed, cancer kids, kids who are long-term on oral steroids for whatever that be, kidney disease or anything else that causes them to be on long-term chronic oral steroids, children with immunodeficiencies, they are at the very highest risk. They do not mount an appropriate immune response and they get sick as snot, literally. So, so those are very high risk. Children with diabetes, children who are obese are at mildly higher risk, just like children with asthma. And if you have those children in your office and they have the tendency to get sick a lot on you, you should consider some of these interventions like dexamethasone when you're watching them in your office.
Great. Again, such a timely talk for what's going on in our community. We're running out of time. Some of the extra questions that are coming in,
Sure.
I will get to you. We do have the evaluation and the certificate request. Please use the link in the chat. I will also be sending out a reminder email. The webinar has been recorded, and we will have Dr. Dane's slides available as well that you can reference. And with these, I will also put these 4 websites in my follow-up email to everybody, so you have an active link. And with that, thank you, Dr. Danes, and thank you to the Southeast Arizona Area Health Education Center and the Santa Cruz County Adolescent Wellness Networks for getting this program together and out to the public.
And I promise I will answer the other questions in the chat if you give me the other questions in the chat, so we can send an email out with the slides.
I will do so, and thank you much, everybody.
Okay, thank you.